Today we will be studying about ectopic pregnancy. So ectopic pregnancy is defined as any pregnancy that is implanted outside the endometrial cavity. So the problem being with these endometrial pregnancies that is considered to be one of the main causes of maternal death, especially in the first trimester of pregnancy. So when we consider ectopic pregnancy, there are several types. Commonest one is involving the tube. 95% of the time, ectopic pregnancy will involve the tube. We call them tubal ectopic pregnancies. So when we consider the tubal ectopic pregnancies, most of the time, the portion of the tube which is involved is ampullary portion of the tube. And sometimes the middle part of the tube or the isthmus of the tube can be involved. And comparing the other types of ectopic pregnancies, non-tubal ectopic pregnancy, which is around 5% of the incidence, can involve abdominal cavity, the cervical region, the interstitial part of the tube, or a cornual region of a unicornuate uterus, or sometimes rarely the ovary. And also, if the patient has a previous cesarean delivery, sometimes the ectopic pregnancy can involve the previous cesarean scar. When we consider the risk factors for ectopic pregnancy, the commonest risk factor is the past history of ectopic pregnancy. Whatever the treatment modality that we provide for the patient, usually the patient will have 20% risk of having ectopic pregnancy in the next pregnancy if she had a past history of ectopic pregnancy. And any history of past pelvic surgeries, and if the patient has undergone tubal sterilization procedure which has been failed, or any history of pelvic inflammatory disease, or sexual promiscuity, smoking, and if the pregnancy is achieved using assisted reproductive technology such as IUI or IVF, the risk of ectopic pregnancy goes up. The diagnosis is clinical, which is aided by ultrasound scan. So any woman who is in their reproductive age group can be pregnant, and it can be ectopic pregnancy. So any woman who presents with the period of amenorrhea with a positive urine HCG test, that we should be vigilant enough to suspect ectopic pregnancy unless proven otherwise. So in the history, we should ask for the last regular menstrual period and calculate the period of gestation and check the urine HCG test and see whether the patient is pregnant. And if she is pregnant, that we have to query about whether she had her conception naturally or ART is used. And usually these patients present to the accident admission ward or the gynae ward with bleeding, abdominal pain, and sometimes in severe cases in shock. So the symptoms wise, abdominal pelvic pain, vaginal bleeding, or passage of retained products, sometimes with a POA, we should always do a urine HCG test and confirm whether the patient is pregnant or not. With the ruptured tubal ectopic pregnancy, the patient may have urinary frequency or diarrhea due to the peritoneal irritation by the intraperitoneal bleeding. And sometimes the diaphragmatic irritation can cause shoulder tip pain. And because of the hemorrhage, and the patient may be on hemorrhagic shock, which causes dizziness, faintishness, or syncope. And if this ectopic mass is pushing on the rectum or the sigmoid colon, the patient may have rectal pressure or pain while defecation. So when we get a patient like that, we have to examine to exclude the other differential diagnoses, which are this patient may be pregnant, having an intrauterine pregnancy and bleeding with a threatened miscarriage, or actually ectopic pregnancy, or maybe bleeding due to any other gynecological cause. So in general examination, we have to check the pulse rate to see whether the patient is tachycardic and measure the blood pressure to see whether the patient is hypotensive, and reduced capillary refill time and pale conjunctiva is indication of massive hemorrhage. Sometimes rather than tachycardia, because the peritoneal distension may cause bradycardia, so we should be vigilant enough to identify that. In the abdominal examination, we should try to palpate the uterus, and most of the time in gynecological patients and the early pregnancy, you will not be able to palpate the fundus, and evidence of any other pelvic masses, which may explain the pain that the patient is having, and evidence of intraperitoneal bleeding, such as generalized tenderness, rigidity, and guarding. And we should offer a vaginal examination. So the speculum examination will give us some idea about the cervix and any other local causes of PV bleeding, such as polyps, cervical edema, or cervicitis. And the vaginal examination will give us some other features, such as cervical motion tenderness, and sometimes we may see the patient may have bilateral or unilateral adnexial tenderness. So the diagnosis of the ectopic pregnancy is used by transvaginal ultrasound scan. It is a single best diagnostic modality, and the sensitivity and the specificity is around 99%, which when it has been done by a experienced operator. So when a woman presents with abdominal pain or vaginal bleeding in reproductive age group who is sexually active, we should prompt for a urine pregnancy test. And if it is positive, we should offer early ultrasound scan, specifically a transvaginal ultrasound scan, to see the location of the pregnancy. So usually visualization of intrauterine pregnancy generally excludes the diagnosis of ectopic pregnancy, but we should keep in our mind there is a very rare possibility of a heterotropic pregnancy, which means that there is intrauterine and extrauterine pregnancy both in the same time. And if the urine HCG is positive, but we can't see a pregnancy using ultrasound scan, it is diagnosed as pregnancy of unknown location. So it's a different matter compared to the ectopic pregnancy, but pregnancy of unknown location can be a failed pregnancy or an early intrauterine pregnancy, and sometimes an ectopic pregnancy which we can't see at the moment. So this pregnancy of unknown location is a term that we use in the early part of the pregnancy or as a gynecology. So if the patient is having a POA and a positive urine HCG test, but in the ultrasound scan, if we can't see a pregnancy, intrauterine or extrauterine, we label them as pregnancy of unknown location. In such instant, we have to do a serum beta HCG level to confirm. And according to the initial value, we have to repeat the beta HCG level in 48 hours. And if the pregnancy is indeed the viable intrauterine pregnancy, there would be a rise in beta HCG level by 66% or 48 hours. And if it is a failing pregnancy, either ectopic or an intrauterine pregnancy, there will be a drop in beta HCG more than 50%. In between, the levels does not rise more than 65%, or if they do not drop more than 50%, there is a high chance the patient is having ectopic pregnancy, but we can't visualize it using the ultrasound scan. And as a rule of thumb, when the beta HCG level is more than 1500, we should be able to see something using the transvaginal ultrasound scan. And when it is more than 3000, that pregnancy should be visualized using a transabdominal scan even. And sometimes we can use progesterone to confirm a viable pregnancy in the state of pregnancy of unknown location, or the PUL. If the progesterone level is more than 25 nanomoles per liter, there is a high chance that the patient is having an early IUP, which we can't see. But in the context of ectopic pregnancy, we should not be checking the progesterone levels. The test is beta HCG level. So when we diagnose ectopic pregnancy, there can be management in two lines. The patient may be in shock and the patient may be hemodynamically stable or the ectopic is not ruptured. If the patient is hemodynamically unstable, initially we have to stabilize the patient, and the management is surgical management. In the surgical management, we can either go for open surgery, laparotomy, or a laparoscopic surgery, and to sort out the ectopic pregnancy. So the surgical modality can be either a salpingectomy, means that we remove the tube, or salpingotomy, that means we open up the tube and try to remove the products of conception. I will come to that part later, but in a hemodynamically unstable patient, the management is always surgical. But if we diagnose ectopic pregnancy before it's ruptured, and if the patient is hemodynamically stable, the management depends on several indications. So we can use expectant management, medical management, or surgical management. So I will go through the surgical management first. So if the patient's ectopic pregnancy, the ectopic mass in the ultrasound scan is more than 35 millimeters, or in the ectopic pregnancy, sometimes we can rarely see the heartbeat. The heartbeat can be seen, or the initial beta HCG value we do is more than 5,000. We have to offer surgical treatment as the first option because there is a high chance this can rupture and the patient may develop hemorrhagic shock. And in such instant that also the patient is having trouble with follow-up, or if she is not willing for a methotrexate treatment, we can offer surgical management. Or if the initial beta HCG value is less than 1,000 and there are no indications for surgical management, we can offer them expectant management. In expectant management, we would be doing nothing and we'll be monitoring the patient to see whether she goes into rupture of the ectopic. So to do that, we will be monitoring the serial beta HCG values. Initial value should be less than 1,000. And after that, we will do another value at day 4 and day 7. And we should be able to see a drop more than 15% from the initial value during this serial assessment. If it is dropping, then we can do weekly serum beta HCG values until it becomes negative, which is less than 20 international units per liter. And the good thing about the expected management that because we are not doing a surgical management, the surgical morbidity and mortality and the anesthetic complications are less, and that the damage in the tube is minimal. And if the beta HCG value is less than 1,500, and if there is no features of any indication to do surgical management, we can offer them medical management. The drug of choice is methotrexate. But we have to make sure when we are giving methotrexate that the patient is not having a heterotropic pregnancy, because the methotrexate will cause the intrauterine pregnancy if they are having to abort. And this methotrexate is an antifolate drug, and the dosage that we should give methotrexate around 50 milligrams per square meter body surface area. So the drug dose is calculated according to body surface area. So body surface area calculation will depend on the weight and the height and the age of the patient, which we can use a nomogram to calculate. And we usually give single dose, IM single dose. And we usually check beta HCG values on day 4 and day 7. And if the drop is more than 15% between day 4 and day 7, we consider the treatment to be success and we offer the patient weekly beta HCG like the expectant management until it becomes negative. But before we give methotrexate, there are several prerequisites we have to check. We have to do full blood count to see the patient's WBC count and a liver function to see patient's AST and ALT level. Because methotrexate can cause agranulocytosis and it can cause liver failure. If the patient's beta HCG values are not dropping or if they are static, the clinician can offer another dose of methotrexate or offer surgical management. So, as I explained previously, in the expectant management, we check the beta HCG levels on day 4 and day 7, and the levels drop by 15 or more. Then we have to repeat it until it becomes negative. This, if does not fall, we have to discuss with the patient and offer the surgical management. Methotrexate, the same principle applied as I explained earlier. Between day 4 and day 7, there should be a drop more than 15%. So as I explained earlier, the methotrexate is a folic acid antagonist. So it can cause nausea and mouth ulcers, pancytopenia. That's why we have to do the full blood count before we give methotrexate. And there can be transient elevation of transaminases. That's why we need to do AST ALT before we start. So in the surgical management, either for ruptured ectopic pregnancy with hemodynamical instability, or if the patient has unruptured ectopic but there are indications for surgical management, we can offer the same surgical management. So it can be either a salpingectomy or a salpingotomy. So open or laparoscopic approach can be used in a hemodynamically unstable patient. Even if the skilled operator is available, we can offer laparoscopy because compared to laparotomy, laparoscopy has a lot of advantages such as good cosmetic outcome, less need of pain, and early recovery and early achieving normal day-to-day activities. In a patient who has unruptured tubal ectopic, who has indication for surgical management, definitely we have to follow the laparoscopic approach. Whether to do a salpingectomy or the salpingotomy depends on the patient's history. Salpingectomy we offer if the patient doesn't have any features suggestive of tubal damage and if the patient doesn't have any history of subfertility. We offer salpingectomy because in such instances with a single tube, the achieving pregnancy compared to having two tubes, there is no statistical significant difference. And we will be eliminating having a recurrence in that deformed tube. And patient does not need beta HCG assessment after the salpingectomy. She can do a urine HCG in 3 weeks from the surgical management. If it is negative, there is no follow-up. In salpingotomy, we offer salpingotomy means that we open up the tube and remove the products of conception. If the patient have past history of subfertility, or if the patient's other side tube is damaged, or even maybe she had a previous surgery on that tube. But the problem is that salpingotomy in 20% of the women may need another surgery, like as another surgical management or methotrexate treatment. And they have to do beta HCG assessment serially weekly until it becomes negative. So in laparoscopic salpingotomy, we lengthwise linear incision is made over the fallopian tube and everything is removed. And in salpingectomy, we remove the fallopian tube. So in patients who are having rhesus negative blood group and who are not previously sensitized, we have to give rhesus prophylaxis as dose of 250 international units of anti-D if we are giving surgical management. But if we are giving medical or only expectant management, we don't need to give anti-D prophylaxis, and there is no indication for clay-Hoover testing. For this topic, there are several guidelines that you can follow for further reading. So there is a guideline by NICE, which has been updated at 2021 regarding ectopic pregnancy and miscarriage. And there is also a green top guideline, which has been by 2016. Thank you.